right now, there are thousands of people paying top dollar to have highly purified salmon DNA injected directly into their
Yeah,
faces.
it's wild when you say it like that.
Right. I mean, it's literally one of the most sought after aesthetic treatments right now for, turning back the clock on aging.
Absolutely.
But for a specific group of people like Duty, those living with really complex autoimmune conditions, this massive beauty trend is quite literally handing their immune system the exact weapon it has been hunting for.
It's a huge biological clash, yeah.
Welcome to the deep dive. Today, we're exploring this really fascinating intersection between high-end aesthetic medicine and the deeply complex world of human immunology.
That's such an interesting crossover.
It really is. And we're pulling from a pretty massive stack of sources to make sense of this. On the clinical side, we've got aesthetic practice guidelines from places like Rejuva London and Eternia MedSpa, along with training protocols from Harley Academy.
Right, and we're also pulling insights from Dr. Caroline Warden to get that practical clinic perspective.
Exactly. But to balance that, we're cross-referencing it with some dense, really cutting-edge immunological research papers.
Oh yeah, heavy stuff from journals like Frontiers and PLOS Pathogens.
We're basically looking at the fundamental cellular defense systems of the human body.
Which is where it gets really complicated.
So our specific focus today is the critical set of precautions necessary when administering these DNA-based treatments.
Right, the polynucleotides.
Yes, administering those to patients who have active autoimmune diseases, and specifically systemic lupus erythematosus, or SLE.
That's the big one we're looking at.
Now, for you listening, whether you're, managing an autoimmune condition yourself, or maybe you're considering one of these aesthetic treatments, or you just really love understanding the bizarre ways the human body works,
Which I definitely do.
this exploration is going to reveal just how deeply intertwined our cosmetic desires are with our basic biology. Combining cosmetic injectables with autoimmune conditions is like trying to install a new flashy aesthetic feature in a building.
Well, I like this analogy.
While its highly sensitive security alarm is currently glitching out.
Yeah, you have to know exactly which wires not to cross.
Exactly. You can't just treat the surface of the skin without, talking to the immune system underneath.
Because the skin isn't just some inert canvas, right? It's a living, breathing, and sometimes highly reactive biological ecosystem.
Right.
So when you breach the scare barrier to introduce a foreign material, you are literally forcing a conversation between that material and the body's immune sensors.
Okay, let's unpack this, because before we talk about the disease, we really have to understand the treatment itself.
That makes sense.
Based on the aesthetic clinic guidelines we reviewed, these polynucleotides operate on a completely different level than traditional dermal fillers.
Oh, entirely different.
Because most of us know about standard fillers made of hyaluronic acid, right? HA fillers.
Yeah, the classic lip and cheek fillers.
From my understanding, HA fillers are essentially just cross-linked gels. They act like architectural support.
Exactly, they're hygroscopic, so they pull in water.
Right. They pull in water, occupy physical space, and literally just push the tissue up to smooth out a wrinkle. They seem, relatively passive.
They are, but when you look at the literature on polynucleotides, they aren't passive at all. The sources specifically describe them as biostimulators.
Biostimulators, meaning they actively do something.
Right. They are highly purified, sterile injectables derived from fish DNA, mostly salmon or trout.
Which still sounds crazy.
It does. But instead of just sitting in the tissue taking up space, they act as active molecular messengers.
And that contrast right there seems fundamental to why the medical screening for these treatments has to be so intense.
It is. You are moving from a passive implant to an active biological signal.
So what actually happens when it goes in?
Well, when these concentrated DNA fragments are injected into the dermal layer, they actually bind to specific receptors on the surface of your own skin cells, your fibroblasts.
Okay.
And that binding action sends a signal to the fibroblast to wake up, increase its metabolic activity, and start manufacturing fresh collagen and elastin.
So over time, that regenerative cascade is what improves the actual cellular quality and elasticity of the tissue.
Exactly. It's regenerating from within.
Which is just fascinating from an evolutionary biology standpoint. The idea that a nucleic acid sequence from a fish
Right, salmon.
can just perfectly dock with a human skin cell receptor, it feels like a glitch in the matrix.
It really does. But it highlights how highly conserved these basic biological building blocks are across totally different species.
Human cells just recognize the nucleic acid structure and read it as this universal signal for tissue repair?
Yeah, that evolutionary overlap is what makes the whole treatment possible. But I should definitely reassure you, and this is based on Dr. Caroline Worden's clinical guideline.
Oh, right, the genetics thing.
Yeah, injecting salmon DNA does not alter human genetic material.
Okay, good to clarify. No one is turning into a fish.
Exactly. The injected polynucleotides do not integrate into the patient's own genome. They operate entirely as temporary signaling molecules.
They trigger the healing cascade, and then what?
Then they're just naturally degraded and metabolized by the body's own enzymes.
Okay, so we have this biological messenger designed specifically to provoke an active tissue response and stimulate local immune and healing pathways.
Right.
Which brings us to my big question, and really the central conflict of our sources today.
Go for it.
If these injectables are specifically designed to wake up the skin's healing and immune responses, what happens if a patient's immune system is already malfunctioning and, in overdrive?
Well, that is the exact reason why rigorous medical screening is vital.
Because it's not just a passive gel anymore.
Exactly. The aesthetic literature refers to this as a contraindication, but the immunology papers really explain the underlying mechanics of why it's so dangerous.
Right.
Introducing a biostimulator into an environment where the immune system is hypervigilant, which is literally the defining characteristic of an autoimmune disease, it provokes a completely different set of reactions than it would in a healthy patient.
So let's look at systemic lupus erythematosus specifically, because SLE provides probably the most striking example of this biological clash.
It really does.
The immunology papers from Frontiers and PLOS Pathogens, they identify SLE as a disease heavily characterized by the presence of anti-DNA antibodies.
Yes, that's a critical term, anti-DNA antibodies.
So essentially, in a healthy person, the immune system just ignores the body's own DNA. But in SLE, the immune system loses its tolerance to autoantigens.
Right, that's recognizing what's friendly.
It sees extracellular DNA like mitochondrial DNA or self-DNA from damaged cells as this dangerous invader, right?
Exactly. To really understand the danger here, we have to look inside the cell, specifically at a microscopic structure called the endosome.
The endosome.
Yeah. Think of the endosome as the cell's internal sorting facility and garbage disposal.
Okay, sorting facility.
When a cell engulfs debris from its environment, which often includes the shredded genetic remains of invading viruses or bacteria, it sends that material to the endosome.
Just to clean up the cellular neighborhood.
Right. And living inside that garbage disposal are specialized sensors. The most notable one is called TLR9, or Toll-like receptor 9.
TLR9.
Its entire biological purpose is to detect the DNA of pathogens mixed in with the cellular trash and, sound the alarm.
Okay, so it's essentially this internal security guard scanning for foreign genetic material.
That's a great way to picture it.
But in SLE, this system misfires catastrophically, doesn't it?
Oh, completely.
Because normal cellular turnover happens every day, cells die off, and bits of the patient's own DNA end up floating in the extracellular space.
Exactly. In a healthy person, the body sweeps that up silently. No alarm.
But in an SLE patient, that self-DNA gets pulled into the endosomes, and that TLR9 sensor trips the alarm as if it were some massive, life-threatening viral infection.
Yes. The breakdown of tolerance literally turns the immune system against itself. The sensors just cannot differentiate between viral nucleic acids and the patient's own nucleic acid.
Wow.
And it gets worse because the literature highlights a secondary pathway called CGA sting.
CGS sting? That sounds intense.
It is. It operates in the main fluid of the cell, the cytoplasm. When these sensors detect rogue extracellular DNA, they don't just cause a little local irritation.
What do?
They initiate a massive systemic inflammatory loop. They drive the production of interferons and pro-inflammatory cytokines.
Ah, so that's what causes the real damage.
Right. This relentless inflammatory cascade is what ultimately leads to the severe tissue and organ damage we see in lupus.
Like lupus nephritis affecting the kidneys or severe cutaneous lupus damaging the skin?
Exactly.
Here's where it gets really interesting.
Yep.
When you connect the dots for the listener here, SLE patients have an immune system that is literally weaponized against DNA.
Yes.
Therefore, injecting polynucleotides means you are voluntarily introducing the exact type of molecule, these DNA fragments, that their immune system is primed to violently attack.
That is the core issue right there.
Because of this molecular clash, the timing of any aesthetic treatment becomes a matter of strict medical safety. It's not just about looking good anymore.
Not at all. And the clinical reality of that molecular clash is why the status of the patient's disease dictates whether treatment is even a remote possibility.
Right. The guidelines are pretty strict about this.
Very. According to the guidelines from sources like Harley Academy, performing any biostimulatory treatment during an active flare of an autoimmune disease is an absolute contraindication.
A hard no.
A hard no, because an active flare implies that the disease pathology is currently elevated.
So they might have active organ involvement or active skin lesions.
Exactly, or active vascular inflammation. Introducing a biostimulator into that active autoimmune environment can trigger a severely exaggerated local or systemic immune response.
Which makes sense. I mean, if we use an analogy, it's like walking into a room where a fire is already burning and deciding it's a good time to spray highly flammable perfume.
That is exactly what it's like. It's guaranteed to cause a flare-up.
And the sources specifically mention a particular risk here, right? Something called ASIA.
Yes, ASIA. It stands for autoimmune inflammatory syndrome, induced by adjuvants.
Autoimmune syndrome, induced by adjuvants. Oh.
Right. So normally an adjuvant is something we talk about in vaccines, a substance added to supercharge the immune response.
But here, the injected material itself is acting as an adjuvant.
Exactly. In an active flare, the polynucleotides act as an adjuvant that basically pours gasoline on the autoimmune attack.
Wow. So treating during an active flare is just completely off the table.
Absolutely.
But what if the fire is put out? What if the SLE patient is currently stable? Is treatment permanently off the table for them too?
Well, this is where we get into relative contraindication.
The gray area.
Yeah, the gray area. According to aesthetic clinic sources like Harley Academy and Dr. Caroline Warden, having an autoimmune disease isn't always a blanket no from some website checklist.
Okay, so there is some wiggle room.
A little. If the disease is stable, treatment might be possible, but it requires extreme caution and, crucially, clearance from the patient's rheumatologist.
But wait, let me push back on that logically.
Sure.
If a patient is severely stable, it's usually because they are on heavy immunosuppressive drugs, right? Like high-dose steroids or biologics.
That's usually the case, yes.
So doesn't that mean their immune system is suppressed and actually won't react to the salmon DNA?
I love this critical thinking. You are right that the immunosuppressants might stop the autoimmune reaction to the DNA.
Right.
But, and it's a huge but, they simultaneously alter the body's normal healing process.
Oh.
And they severely raise the risk of acute bacterial infections.
Because they don't have the immune defense to fight off normal germs.
Exactly. Since polynucleotide injections involve repeatedly breaching the skin barrier with a needle, lots of little needle pokes.
Right, it's not just one shot.
Exactly. The risk of a severe infection skyrockets for immunosuppressed patients. The normal skin bacteria just gets pushed down into the dermis.
And the body can't fight it off.
Exactly. And there's an additional precaution we have to consider: the complication of emergency management.
Emergency management. Like if something goes wrong during the aesthetic procedure.
Right. If a patient has an adverse reaction to the aesthetic treatment, say a vascular occlusion or a severe inflammatory response, the drugs used to fix it, like systemic steroids or heavy antibiotics.
Let me guess, they interact with the lupus meds.
Yes. They could dangerously interact with their already complex autoimmune medication regimen.
You're trying to fix a cosmetic issue, and you end up destabilizing their entire systemic health.
Exactly. It's incredibly risky.
So what does this all mean? Moving from clinical theory to practical advice for you, the listener.
Right, because knowledge is only valuable when applied.
Exactly. And the big takeaway here is that the aesthetic industry is fundamentally medical.
It really is. Patients must be radically transparent with their practitioners.
Radical transparency. No hiding things just to get the treatment.
Exactly. You have to disclose everything during the consultation: recent viral infections, any changes in medication, history of keloid scarring.
Because keloid scarring shows your skin already has an abnormal healing response?
Right, and you even have to disclose if you have a severe allergy to fish or seafood.
Oh, because the polynucleotides are derived from salmon and trout.
Yes, it's another absolute contraindication. Even though it's highly purified, the microscopic risk of residual proteins causing anaphylaxis is just too high.
It makes total sense. I want to add another crucial takeaway from the sources, specifically about medication.
What's important?
Patients should never stop taking their autoimmune medications or blood thinners just to safely fit in an elective cosmetic treatment.
Never.
I mean, we read stories about people going off their meds so they won't bruise as much.
It's incredibly dangerous. Systemic medical care must always take priority. Sometimes the safest medical decision is simply to walk away and not treat.
Yeah, you just have to say no.
A responsible practitioner will tell you no.
Okay, to briefly recap this journey we've been on, we started by understanding how polynucleotides actually stimulate the skin using fish DNA to wake up cellular regeneration.
Right. Active messengers, not passive fillers.
Then we dove into the cellular warfare of SLE, where the immune system is literally primed to attack that exact kind of DNA.
The TLR9 sensors misfiring.
Exactly. And finally, we looked at the precise medical precautions required to navigate the two safely, why active flares are a hard no, and why stable patients on immunosuppressants face severe infection risks.
It's all about navigating that very narrow, complex biological reality.
It really is. Now, I want to leave you with one final kind of mind-bending paradox pulled straight from the immunological sources we reviewed.
This is my favorite part.
We just spent this entire deep dive exploring how injecting DNA polynucleotides can be incredibly dangerous for SLE patients because their immune system attacks DNA, right?
Right, it triggers the flare.
However, pharmaceutical scientists are currently developing highly modified synthetic polynucleotides to act as cures for SLE.
Wait, really? The same thing that causes it?
Yes, they are specifically designing synthetic TLR7 and TLR9 inhibitors. By engineering the DNA sequences to block the immune sensors rather than trigger them, it jams the lock.
Oh, wow. So they're using the exact same pathway.
Exactly. The very class of molecule that causes a disease flare might soon hold the blueprint for its cure.
That is just brilliant.
It really is. It's all about the exact molecular structure. So for everyone listening, keep questioning the science behind everyday treatments. Don't just take the marketing at face value.
Dig into the biology.
Always look deeper. Thanks for joining us on this deep dive, and we'll catch you next time.